There was a trial called the Mandala trial, which showed that this combination reduced exacerbations in patients with moderate to severe asthma. But how about in mild asthma? And that's where this trial comes in.
All right, what do they find? Good news? Bad news?
This is the Rounds Table. All right, welcome back, Rounds Table listeners. New episode in store for you today, and it is both John and I. We have two articles we're going to review. They are only loosely related, so we'll build up some suspense until you hear what they are. John, what article is up first?
So first, it's the effects of hypotension avoidance versus hypertension avoidance strategy on neurocognitive outcomes for non-cardiac surgery. This was by Maracucci et al., published in the Annals of Internal Medicine, June 3rd, 2025. And as a segue, side note, shout out to my colleague Kelly Zarnke. He's an internal medicine specialist who I work with at the Foothills, and he was a co-author on the paper.
Impressive. Congrats to Kelly on getting this published in a great journal. And it really feels like it answers a question which is relevant and comes up, on periop medicine. So what was the research question here?
The question here was, what effects do perioperative hypotension avoidance versus hypertension avoidance strategies have on delirium as well as 1-year cognitive decline after non-cardiac surgery?
Yeah, I vaguely remember when I was in R3 on my med consults rotation up at Sunnybrook with Don Rettelmeyer, come to think of it. And he had many theories related to why post-op delirium occurs. I would need to fact check to remember if, intra-op hypotension was one of them. But why did this article catch your eye?
Yeah, so post-operative delirium is common. It affects up to 20% of patients undergoing non-cardiac surgery. And delirium is bad for lots of reasons, including being associated with long-term cognitive impairment and risk for dementia. However, even in the absence of delirium, up to 30% of older patients undergoing non-cardiac surgery have substantial cognitive changes 1 year later. Now, the role of blood pressure control and the impact that it has on neurocognitive impairment is not clear. It does make sense to worry that hypotension could lead to cerebral hypoperfusion, which could then have some role in neurocognitive outcomes being impaired. Observational data has suggested that both hypotension but also hypertension can increase risk for post-operative delirium. There is some randomized control trial data that comes from a few small clinical trials, but otherwise it doesn't show a clear, consistent association. So here, the COG-POISE-3 trial set out to assess the impact of hypotension avoidance versus hypertension avoidance on neurocognitive outcomes.
Interesting. Yeah, I get the impetus for sure. I'm a little bit skeptical that a bit of hypotension intra-op could lead to, dementia years down the line, but I've been wrong many times before. So what was the study design here?
So the POISE-3 trial was this large international randomized control trial, and within that, there was this blood pressure management aspect of the trial. That ultimately showed no difference in cardiovascular outcomes for patients undergoing non-cardiac surgery between a hypotension avoidance versus hypertension avoidance strategy. COG-POISE-3 was a sub-study. The population here, so it was patients aged 45 years of age and older undergoing non-cardiac surgery, requiring at least one overnight stay, and they had to have a history of vascular disease or multiple vascular risk factors. They also had to be receiving one or more antihypertensive medications for 30 days or more in the 6 weeks preceding randomization. For this sub-study, patients with dementia were excluded. For the intervention, it was a little bit complicated, but patients were randomized to either hypotension avoidance or hypertension avoidance. All patients were instructed not to take their antihypertensive medications the night before and the morning of surgery. For those randomized to the hypotension avoidance strategy, the anesthesiologist was told to target an intra-op MAP of 80 or greater from the time of anesthetic induction until the end of surgery. And this could include strategies like using fluids, vasopressors, or combinations of both. As well, on the day of surgery and during the first 2 days after surgery, patients were not to receive any ACE inhibitor, ARB, or direct renin inhibitor. The other medications were managed in a stepwise manner via an algorithm that was dependent on the patient's blood pressure. For those that were randomized to the hypertension avoidance strategy, anesthesiologists were targeting a MAP of 60 or greater. Patients were to receive all of their usual blood pressure medications the morning of surgery and then also restart them immediately after surgery. So for the outcomes, The primary outcome of interest was in-hospital delirium during the first 3 post-operative days. There were also 2 main secondary outcomes, including one getting at the severity of delirium and the other was looking at 1-year cognitive outcomes. For outcome ascertainment, so they had trained study personnel who screened participants twice daily from post-op day 1 until post-op day 3, discharge, delirium diagnosis, or whichever came first. Delirium was diagnosed using something called the 3-minute diagnostic interview for confusion assessment method, and I admittedly don't know what that is. But looking quickly, 3D-CAM takes into account 22 items that, as the name suggests, can be obtained during a 3-minute interview. It has a sensitivity of 95% and a specificity of 94%. They also administered the MoCA and another neurocognitive test called the digit symbol substitution test at baseline and at 1 year following surgery. And this was an intention to treat analysis.
Interesting. Okay, so this was actually not its own RCT. It was a sub-study of POISE-3, which makes sense because I thought I'd heard that name before. And really, they were randomized to either target a MAP of 80 intraoperatively to avoid hypotension. That was one arm of randomization. The other arm of randomization was to avoid hypertension, and therefore the anesthesiologist targeted a lower MAP of 60 or greater. Do I kind of have that right?
Totally. And then, also the caveat that their blood pressure medications taken the days leading up to surgery were then altered depending on which strategy they were randomized to.
Okay, gotcha. Yeah, and the only reason why I know about the 3D-CAM is kudos to Nathan Stahl, who taught me about this. This is what we are using for our A donut randomized trial for outcome assessment, and that randomized trial, not related to periop, but related to, do antibiotics help older adults who have bacteria in their urine, but they're afebrile and they're delirious? But anyway, that is a trial in progress. Back to the COG POISE-3, what did the included patients look like?
So there were about 1,300 patients randomized to the hypotension avoidance strategy and about 1,290 to the hypertension avoidance arm. The mean age was 70, about 50% were male. Patients were on all kinds of antihypertensive medications, but the majority were on an ACE or an ARB at about 70%. About 46% were on a beta blocker, 35% on a calcium channel blocker, and 22% on a thiazide diuretic. Looking at the surgical cases, about 39% of the surgical cases were for general surgery, 30% were for orthopedic surgeries, 10% for vascular, and 10% for urologic.
Interesting. Okay. And what did they find here for the primary outcome?
So delirium occurred in 7.3% of patients in the hypotension avoidance group and 7% in the hypertension avoidance group, a finding that was not statistically significant. For one of the main secondary outcomes, which was 1 year cognitive outcomes, there was also no statistically significant difference.
Yeah. And I mean, I guess I'm not totally surprised. I feel like post-op delirium occurs for many, many different reasons and is multifactorial. And I guess this study at least suggests that how low or high grandma's blood pressure was intra-op probably is unrelated to the risk of post-op delirium. Do I kind of have that right?
Yeah, I think so. The authors really speak to that too, about their underlying hypothesis. Before jumping to that, other considerations and limitations of this trial, COVID-19, we can't forget about COVID. It did get in the way of recruitment for this trial, and it led to smaller than expected sample sizes. And then there were also lower than expected completion rates for the follow-up data on the 1 year MoCA, for example. And now speaking to the details of the trial, it was this kind of complicated intervention strategy, and adherence rates were a bit on the lower side. So one of the questions would be whether this impacted the ability to find a true difference. However, with subgroup analysis and dose response effects based on the degree of adherence, there was no clear signal that this played a role. And instead, the authors said that they actually suspected their underlying hypothesis that perioperative hemodynamics would impact neurocognitive outcomes was wrong.
Interesting. Okay. So what's the take-home point?
There were no differences found in neurocognitive outcomes for patients undergoing non-cardiac surgery when comparing a hypotension avoidance versus hypertension avoidance strategy.
Okay. And you are not an anesthesiologist, but is this practice changing for your anesthesiology colleagues at Foothills?
Yeah, I think it's practice affirming. I will certainly not make any recommendations to anesthesia for what MAP to target intraoperatively.
Yeah, I find some med consults, summary and plan notes are just so over the top. Like, anesthesia, please consider this. Like, surgeon, please consider that. No. Stay in your lane. All they want to hear from you is that green light, no major reason to not proceed with surgery. Okay, and end of editorializing for me for now. Before we go on to the next article, a quick note from our sponsor. On Rounds Table, we usually focus on the latest in clinical research, predominantly trials and treatment updates. But today, a quick shift. We're talking scrubs, specifically FIGs. That's right, we have a new sponsor.
For those that don't know, they're comfortable, durable, and actually built for people in healthcare. No scratchy fabric, no boxy fit, just thoughtful design that makes your day easier.
Yeah, and tons of pockets, even for your stethoscope. And yes, I am still using a stethoscope, listeners. The antimicrobial fabric, and they come out of the wash ready to go.
A few that we like, there's the Katarina top and Cade pants for women, or the Leon top and Tansin joggers for men. They're simple, functional, and easy to move in, and really, really comfortable.
Yeah, totally agree. When I was telling Britt about our sponsor, she's like, whoa, FIGs, they have some of the best scrubs, and man, are they comfortable. And as a special promo to our listeners, you can get 20% off your first order at wearfigs.com with the code, all caps, FIGSCA. Again, that's wearfigs.com with a code FIGSCA to save 20% on your next purchase. All right, and next up we have As Needed Albuterol Budesonide in Mild Asthma, published in July 2025 in the New England Journal of Medicine. The acronym is BATURA. Bears no resemblance whatsoever to the title of the article, but that will probably be my biggest gripe with this study.
Yeah, and hard to make a connection between perioperative medicine and this trial in asthma, but hey, it just speaks to general internal medicine. You got to think about a little bit about everything. What was the research question here?
For patients with mild asthma, is this combination of albuterol plus budesonide superior to albuterol alone for as needed if somebody feels like their asthma is getting worse?
Okay, why'd you think this was important?
So, interesting brief history lesson. Meter-dosed inhalers, that's like the puffer somebody has in their hand, the blue puffer for Ventolin. Those were introduced back in the 1950s. Before that, patients actually had a bulky nebulizer that they would require when they felt their symptoms were getting worse or they needed their puffers for another reason. Fast forward to the 1980s, glucocorticoids were then also made available as a meter-dosed inhaler. So you had patients that had multiple individual puffers, and historically patients with asthma would have these two separate inhalers, and often it would be some recommendations would be given that, hey, at baseline, use your glucocorticoid, and when you feel symptoms are getting worse, add on your bronchodilator for relief. But when somebody was maybe in the throes of an exacerbation or an exacerbation was coming up, not infrequently, they would forget to take their budesonide and only take their as needed, right? So a little bit of complexity here, even though you think you're being crystal clear. And at some point, I don't know the exact date, this combo inhaler was created of albuterol plus budesonide. For our listeners, albuterol, similar to Ventolin. And there was a trial called the Mandala trial, which showed that this combination reduced exacerbations in patients with moderate to severe asthma. But how about in mild asthma? And that's where this trial comes in.
Okay, cool. So what was the study design?
Yeah, so the study design here, this was a international, multi-center, fully virtual, decentralized, double-blind randomized trial of people aged 12 and up with asthma that was uncontrolled despite SABA, like Ventolin or Albuterol. And I should say Ventolin is the same as salbutamol. So despite having a SABA with or without a low-dose glucocorticoid or a leukotriene receptor antagonist. So, let's get into the sort of PICO of the study itself. So the population were adults with poorly controlled asthma, as mentioned. Bringing this to life, the key inclusion, they had a diagnosis of asthma by a physician. So this study did not require that they had a recent PFT or methacholine challenge, just that a doctor had diagnosed them and confirmed that they had asthma. Active use of the SABA alone, as mentioned, or SABA plus a low-dose ICES or leukotriene receptor antagonist. Self-reported use of the short-acting bronchodilator on more than one occasion in response to symptoms in the past week. How about the exclusion criteria? They excluded patients that had other significant lung diseases like pulmonary fibrosis, COPD, emphysema. They also excluded patients who were hospitalized in the past 3 months, which kind of makes sense because if you're hospitalized in the past 3 months, this is probably not going to be mild asthma. They also excluded patients with a self-reported use of a long-acting bronchodilator, or if they self-reported that they had steroids at home, or if the researcher felt as though they were unlikely to adhere. So what was the intervention? So again, it wasn't standing, it was as needed in both groups. So intervention was as needed fixed dose combination of 180 micrograms albuterol and 160 micrograms budesonide. And each dose consisted of sort of 2 inhalations, and each inhalation having 90 of albuterol and then 80 of budesonide. The comparator, as needed albuterol alone, and same thing, 2 puffs. The outcome was pretty clean. First severe asthma exacerbation in the subsequent 1 year.
Okay, what did patients look like?
So 2,500 were randomized. I'll note up front, only 70% completed the trial. Said differently, 30% of patients had lost to follow-up. Fortunately, that was balanced between the 2 arms. The included patients were predominantly adults, so 97% were over the age of 17, the average age being 43. At baseline, the vast majority were just using the short-acting bronchodilator prior to randomization. 70% were white, nearly 20% were black. Most had asthma for over 20 years, so on average it was diagnosed like 24 years ago. And 11% had a severe exacerbation in the preceding 1 year.
All right, what did they find? Good news? Bad news?
Yeah, good news. So the trial was stopped early for efficacy. So that primary outcome of severe exacerbation within 1 year of randomization occurred in 5% in the albuterol plus budesonide group versus 9% in the albuterol alone group. So that's like a 50% reduction in severe exacerbations, which is pretty impressive. On average, the sort of annualized rate of severe exacerbations was 0.15 in the combo group versus 0.3 in the albuterol alone group. As I mentioned, many patients were lost to follow-up, and the authors conducted sensitivity analyses to, really test the robustness of their findings. And really, despite multiple sensitivity analysis using different approaches for why patients were lost to follow-up, their overall results aligned with that primary finding of a marked reduction in the risk of severe asthma exacerbation. Adverse events were similar between the 2 groups. Serious adverse events occurred in 3% in both groups. Slightly more common with the combination group was sinusitis, but that was generally mild to moderate.
Geez, this seems like a pretty impressive result. Before we get too excited, though, what are some of the limitations?
Yeah, I agree with you. This is an impressive trial, and it's a double-blind study that is so powerful. And the primary outcome was something we care about and patients care about, which is severe exacerbations. But you're right. What are a few limitations? One being the very large loss to follow-up. That's never a good thing. You never want, major loss to follow-up. And if listeners are curious, I would say most randomized trials that you see published in the New England Journal of Medicine have a loss to follow-up like less than 5%, often less than 2%. And this was closer to 30%. Another limitation, this doesn't apply to kids, this doesn't apply to teenagers, but I don't think there's too many pediatricians listening to our show. And also going back to how they identified this population, they don't know with certainty that these people had asthma. They didn't require that they had a methacholine challenge, for example, and they had PFTs.
Yeah, that's kind of tricky, Because, pragmatically, I acknowledge a lot of people do get labeled with a diagnosis without PFTs. But if there's anything that some of my respirology colleagues have impressed upon me, it's that you really do need to try to confirm the diagnosis before you're starting people on treatment.
Yeah, I totally agree with that, Clinical Pearl. Now, the nice thing from a randomized trial perspective is that, that would bias the results towards the null. So if this was a null finding, we'd be scratching our head saying, well, maybe it's because a lot of people didn't have asthma. But in this case, it was not a null finding. It truly showed a reduction, whereas that lack of ground truth information generally biases studies towards a null.
Totally. So what's the takeaway?
I think the take-home point here is that for patients with mild asthma, they should probably be prescribed this combination inhaler of both albuterol plus budesonide and be told, hey, when you feel like your symptoms are getting worse, start taking this, as opposed to like just take albuterol or just take salbutamol.
Okay, practice changing?
Yeah, I actually really think it is. Now, the obvious caveat that we are both hospitalists, so like we don't often see patients who have like mild asthma. Usually we're seeing the more severe cases, but instead I sort of think about some of my friends that have asthma, some of my colleagues who have asthma. And I think for these patients who have mild asthma, this feels like it's practice changing. Sure, maybe we should wait for another randomized trial to confirm these findings, but I don't see any major limitations or major reasons not to sort of already change practice. But I'm curious to hear what the respirologists who listen to our show think.
Sounds great. I like this. I think we've kind of seen similar signals too, like you've already highlighted, that this combo inhaler is useful on an as needed basis. And I think that's a big takeaway message for me.
Yep. All right, John, that is it for today's episode. Good stuff. What caught your eye?
So I finally got around to checking out The Pit. It's that very popular emergency department TV show. And yeah, like it's a production, but overall it's quite entertaining. But I think more than anything, it kind of reminded me to give a nice shout out to all of the emergency docs out there. They have such a tough job seeing the truly undifferentiated patient. And so I give a lot of credit to them for what they do on a daily basis.
Yeah, my time in the SU has me sort of in the ER, like 48 hours straight, almost with a few hours to sleep. And I have a much greater appreciation. They have such a tough job. Anything can walk through the door. Anything can walk through the door. So yeah, totally agree with you. Good stuff on my end. So I think the listeners have heard me talk about the book of one-pagers. It's now been out for a year, which has been super exciting. I think we've sold almost 500 copies, which has been like kind of neat. And now what we're doing, John, is we've turned it into a chatbot. So rather than you reading the physical book, you can just ask it questions like you would ChatGPT. So we just have an alpha version of it. But if any listeners want to get early access to it, free of charge, just shoot me an email. It's fralickmpf@gmail.com.
That's very cool. You're always finding ways to make AI come to work with the stuff you're doing. That's really cool.
Yeah, we'll see how well it works, but appreciate the kind words. All right, John, that's it. Take care, and we'll chat again soon.
Talk to you later, Mike. The Rounds Table is hosted online at medicinepods.com, your one-stop source for comprehensive internal medicine education and evidence-based medicine resources. We can also be found on all of your favorite streaming services. You can also follow us on Instagram, LinkedIn, and X. And special thanks to our audio editor, Tamara Van Bakel.